Good afternoon, those of you on the East Coast, and good morning to everyone in the other 3 time zones that are likely dialed in today. I'm Matt Curtin. You're joining the Pivot Point Consulting and Javion webinar on healthcare AI and its application in getting employees back to work and your patients into brick and mortar facilities to return to productivity and return to revenue much faster. Before I go into introductions, first and foremost, I'd like to thank everyone for being here. I'd like to hope that everybody enjoys the presentation, and I'd like to remind everyone that we've got a few Q&A sessions throughout the presentation. We've got some polling questions, and of course, the all-important post-survey questionnaire where you get to, through digital means, throw Rotten Tomatoes at primarily myself, not our esteemed guest. This webinar is being recorded, so you will receive a link via email with a copy of this, and we encourage you to share the link with your friends, colleagues, and any individuals who need help falling asleep at night and need to hear my voice. So with that, again, I welcome everyone, and we'll start off with saying every single industry across the globe feels the impact of COVID-19. Very obviously, few more feel that than those in healthcare delivery. In a chapter of limited time, budget, focus, and energy, we at Pivot Point Consulting have been seeking out a greater understanding of what organizations are really making a marked difference in the industry, not simply retooling a service or a solution or a product to look and feel like a COVID-aligned product, service, or solution. So with that, I'd like to introduce Dr. John Showalter, clearly MD, MSIS, and Chief Product Officer at Javion. He's also the former Chief Health Information Officer at the University of Mississippi Medical Center in lovely Jackson, Mississippi. Dr. Showalter brings visionary thought leadership on the application of advanced information technology to improving outcomes for patients. His unique education in biomedical engineering, physiology, clinical informatics, and internal medicine has allowed him to work at the intersection of those fields to positively impact patient care and health system efficiency. His work has been recognized with cross-industry awards, including Computerworld's Premier 100 IT Leaders and Health IT Awards such as the Chime Collaboration Award. I said that as if I have a second one there. You'll have to apologize. I'll have to apologize. I'm reading. Dr. Showalter is dedicated to using his passion and knowledge to ensure that Javion's machine has the maximum positive impact for patients. And I'm Matt Curtin, Senior Director of Strategic Growth at Pivot Point Consulting. I'm the Health Strategy and Solution Specialist responsible for executive relationship management, complex engagement architecture, strategic partnership leadership, and delivery alignment. I also focus on macro industry trend alignment, best practice identification, and organizational capabilities. Clearly, I also focus on very creative consulting speak. Now let's take a look at some of the topics Dr. Showalter and I will discuss today. Back to work considerations. Actually, you know what? Let me do this, everybody. Let me go ahead and forward our slides here. Back to work considerations, operationalizing on AI and back to work strategies, using clinical artificial intelligence to rebuild patient trust and accelerate return to revenue, deploying AI to identify patients on a severe course of illness, as well as interventions that can be leveraged to change their risk trajectory. And finally, Q&A. We'll address your questions throughout today's webinar and at the end, so please submit using the Q&A window on your console. Today's webinar is all about the power of data, and the data shows that healthcare organizations are investing in AI. with 62% of healthcare leaders implementing an AI strategy and dramatic market growth. To bolster that, according to Chime's 2019 Most Wired report, 483 organizations described their AI maturity, and the market were at different phases of adoption. I'll pause just for a moment so everyone can take a look at this graphic. So let's start off and get to what's happening today. Dr. Showalter and I came together back via a shared client during my efforts to identify those partners and vendors that were really creating unique solutions that would address the challenges that COVID-19 is posing today. We were really inspired by KLAS's work to put their arms around that using their substantial research depth and breadth. And Javion's name kept popping up. And finally, one of our shared clients said, Matt, you've really got to speak with Javion. They're one of the few organizations that's really looking at things differently and retooling some of their solutions that will have likely a meaningful impact. So Dr. Showalter, can you tell us about what you experienced those first few weeks of COVID? If you could talk a little bit about what are some of the capabilities of the kind of good actors in the market, what you're looking at in terms of indicators of value and relevant solutions.
Sure. And Matt, thank you for the kind introduction. I'm excited to have this conversation. When we began to look at the impacts of COVID-19, we were, like everyone else, kind of caught on our heels and trying to figure out how we can actually help in the industry. And we, like the other companies that we think were really good actors, looked at their core technology, looked at the problems to be solved, and truly adapted, not just put window dressing on the technology, but truly adapted what they were good at to the benefit of to overall. So whether you're looking at some of the chatbot functionality that came from small companies like Twizzle or big companies like Microsoft, they really leaned into what are the communications that have to be happening around COVID-19. How do we help people that are COVID-19 positive so that they can, be sent home, not put in the hospital and still be monitored. When you look at what we were doing, we really looked at our core ability to understand individuals' vulnerabilities, individuals' risk, and began to pivot deeply on that aspect of understanding the vulnerability of a person, and began to do research on past pandemics. Really leaned into the lessons not learned from H1N1, and one of which was the social vulnerability, the community vulnerability. So we began there and really dug into does our technology have the ability to accurately identify and predict which areas are going to have the greatest impact from a morbidity, mortality perspective at the community level, and went through and developed a national insight at the block group level for which block groups were at the highest risk. Back in March, we identified San Quentin as a extremely high risk for COVID-19. Unfortunately, we're seeing that play out over the last couple of weeks with the prison outbreaks. But just with the publicly available information and the underlying understanding from a clinical AI engine, able to create a national understanding at the block group level. So the good actors are taking their core technology, understanding what's needed, what's been missed in the past, and bringing that forward. And unfortunately, the list of vendors that have brought something to market is much more heavily weighted to those that put Windows dressing on something, as opposed to those that really dug in and applied their technology well.
Yeah, that's really insightful. And I recall you mentioning your mission statement when we first started talking about this a few months ago. Maybe you could share that with our audience here.
Yeah, so our mission statement is preventing harm. So everything we do is about reducing preventable harm. And to that end, we partnered with Microsoft, who actually has been a very good actor in this space, and brought forward a COVID vulnerability map that was an interactive map that allows you to dig into what's going on at a block group level, what are the risks at a county level, and it actually was a rather expensive endeavor that Microsoft actually funded for us. So it's built on their Microsoft Azure Map software development kit, but it allowed us to produce something that was clearly needed. Within the first 7 days of making the vulnerability map available, we had over 2 million hits. And that has continued to go upwards. Within the first 2 weeks, we had about 5 million hits. We know we were used by FEMA, by the White House Task Force, all divisions of the military, lots of state and local municipalities, as well as a number of research groups. So it was a need identified during the H1N1 pandemic that really nobody had tackled in the last decade, that we were able to pull together and tackle in a couple weeks.
It must have been quite an amazing journey, evolution in such a short period of time. Can you comment quickly about how you got to overall workplace protection? How did you make that pivot?
Sure. So we built from this community and the response that we got. Our customers began to ask if we could take it from the community to the individual level, and we actually progressed from the community, the social determinants of care, to analyzing the claims and health record data that we had, and scored over 10 million patients and provided those vulnerability back to our clients. Those were used with things like prioritizing mail order pharmacy requests, for prioritizing outreach and calls to individuals, increased attention and triage if people called into a center. So if they were identified as high risk, when they called in and asked a question, it popped up on their screen that that individual's high risk, and they got a higher intensity protocol than those that were at lower risk. The feedback that we received from that, because some of our clients, we actually have their employee-sponsored health plan, and we're scoring on them, and they began to identify, wow, if this patient's really vulnerable, then I don't want them on the front line doing COVID testing. I'm going to put them on, the call bank that we just set up, and that really got us going down the route of the employer workspace. Had a partnership with the Augusta Health Center that made available to the Augusta area an online survey. So we took all of the knowledge that we had generated across, by doing the national analysis and the 10 million patients, and we're able to create an AI-honed survey. That's the most important questions from the AI to generate an understanding of an individual's vulnerability. Turn that into an online survey that's available in the Augusta area for people to come in, understand their individual vulnerability, connect with a healthcare provider about their COVID-19 concerns or about their COVID-19 vulnerability, and really come up with a plan to get back to work and get back to life more safely.
Yeah, I can't tell you how often I have a conversation just with my personal clients around how do they re-engage their workforce to start addressing a now quite delayed IT project roadmap, for example, or at what point in time can they bring consultants back on site? At what point in time can organizations like Pivot Point deploy consultants? These are all pretty big questions. And as I look at what's happening in the market and the utilization of static questionnaires and thermal screening, I wouldn't say that I'm a clinician by any accord, but it feels as if some of those screening elements maybe provide a less than complete quiver to address some of these vulnerability issues.
Yeah, and you know, oh, sorry.
Go ahead.
I would say, so the, you know, we have a framework where we look at, you know, the way that a threat or an infection, an admission to the hospital, you know, how does that interact with the individual and the individual's vulnerability or more modifiable risk factors? So how does the, you know, the age, the genetics, you know, interact with the disease processes, with the social economic determinants that that person's living in, and interact with the overall threat, in this case, COVID-19. A lot of the work that has been going into things is really focused on threat management. You know, the temperature screening, the, you know, masks, social distancing, they're all trying to reduce the threat aspect of it. But we know with the asymptomatic carrier state and the surges that we see, that the threat management side of it is, at least in the U.S., just not going to, you know, maintain the outbreak. So we also need to consider the modifiable pieces, the vulnerability of the patients, and calculating that vulnerability is very difficult. But we know that we are that we're doing it well. You know, our highly vulnerable individuals, you know, have a 1 in 6 chance of being admitted. When we looked at the county level instances, the high-risk counties had mortality rates of, you know, anywhere between 60% and 3 times higher, depending on the state and the disparity within that state. But so we know that we understand which individuals are more vulnerable, and when you overlay an understanding of individuals' vulnerability with the, you know, threat reduction work that's going on, you can have a much greater impact on your overall, you know, patient base or employee base.
So we're going to circle back to that in just a little bit. I think one of the most compelling reasons for this dialogue today, Dr. Showalter, is that you represent a pretty unique intersection with your profile, with your background. So let's talk a little bit more about how you balance, and your own balance of being both a physician and a product executive. I'll ask you to put on now your physician face mask, not hat. Can you talk to us a little bit about what are the hallmarks of a true mission-driven AI organization? Let's kind of raise it up to the market level here. What are those hallmarks, and what would you, how would we say this? What would you wish your peers, physicians, CMIOs, health system leaders, what do you wish they knew about healthcare AI?
Sure. So, I mean, I think any part that starts with, you know, me as a physician, you have to admit that this is kind of a terrifying time for physicians. You know, there's a very few diseases out there that, you know, we don't know how to treat. Most of those that we're not good at treating aren't contagious. So having a really uncurable, untreatable disease, you know, at this point, you know, spreading to hundreds of thousands of people is pretty unprecedented in most modern physicians' histories, right? So this is completely unknown, and in this period of having things be not clear and be very unknown, I think it's important to know that, you know, AI, advanced analytics technologies can really help, and that there are those companies that are mission driven and are, you know, bringing real solutions to the market can help. Unfortunately, there's a lot of noise, and, you know, if there's anything that I would, you know, want them to know is the ability to sort through this noise, although I completely accept how challenging that is right now. I mean, the window dressing on lots and lots of vendors is very real. The window dressing on peer-reviewed literature is very real. People are those with best intents are still rolling research out so fast that we're short-circuiting the peer review journal. There are scary things from a peer review process where, in good faith, great researchers have relied on data sets that have proven to be incomplete or possibly even completely falsely and fraudulently put together and sold for that research to be done. So in an environment where there's a lot coming at you from vendors, where the peer-reviewed research seems less trustworthy than it has before, sorting through the noise becomes really challenging, and finding the partners that you want become really challenging. So I'd like them to know that there are partners out there that they can trust, that there are people out there that can help them sort through the noise and find the right vendor for their problem, the right relationship for their problem, and that right now is a totally okay time to ask for help, because it is everyone's stretched to the limits, and finding what you need when it truly is a needle in the haystack can be very difficult. But clearly the patients out there need the providers finding the right technology, and that it's going to be worthwhile sorting through everything to identify the right solution for your problem.
Really great perspective, Dr. Showalter, and I think you're underscoring some of the frustration that all aspects of the healthcare delivery industry are feeling. So let's continue down this path of addressing both the clinical and business challenges that our friends in healthcare leadership are experiencing. First, we in our audience are really interested in how AI plays a fundamental role in shaping strategies and executing against strategies to bring employees and patients safely and with transparency on their own risk factors back into facilities. There's a little bit to unpack here, so let's start at the top. Dr. Showalter, what are the most common strategies and what might be missing from understanding the risk around COVID-19? I recently read an article, I believe it was the Northwell study, Northwell up in the tri-state area, in which 2/3 of patients hospitalized patients, if I'm not mistaken, presented without a fever. Is this why advanced health IT firms should focus on vulnerability versus symptom detection?
Sure. So, and the one thing I would say there is I don't think that we can walk away from symptom detection, but the most everyone that we've talked to is really focusing on pillars of screening and social distancing. So on the pillars of screening, they're looking at temperature checks, surveys, individual attestations. There's even some AI technology out there that's facial recognition and thermal scanning. So you stand in front of a scanner, it says, "Oh, you're John, and you don't have a fever." You click two things that say, "I don't have a cough, I don't have something else," and you come through the door. The really unfortunate part about that is that people get through, and people don't have a fever. And this is a great study that just shows that from Physicians Weekly, that 2/3 of the patients weren't febrile when they came. They were sick enough to be hospitalized, but they still didn't have a fever. So thermal scanning is going to miss a large chunk of people. Asking about cough and other symptoms are going to also miss a lot of people. A lot of people are having atypical symptoms, or they're having mild symptoms. Confusion with allergies during this time. So is your runny nose COVID or is an allergy? Can be really hard to sort out, especially for healthy individuals. We have people from our company that are young and healthy, but infected with COVID-19 that had none of the typical symptoms for the first several days of their course. we have a pretty liberal, if you don't feel well, don't come to work policy. So they didn't come to work, and then they tested positive for COVID-19. But that's just occurred in, the last 2 weeks. So it's very real that people are not going to get caught by thermal screening and facial recognition and questionnaires. The next piece of technology that people are talking about is social distancing. There are wristbands out there that let you know if you're, they ding if you're within 6 feet of another wristband. The 6 feet even, that's, studies that look at the 6 feet have been done on, ideal conditions. There drafts, wind, have shown that it goes up to 20 feet. There's new argument out there about 220 scientists just appealed to the World Health Organization to identify COVID-19 as airborne because the studies now indicate that it is, spread via microdroplet, not droplet, so that unlike the flu, which is a droplet virus, that COVID-19 may actually be an airborne virus, which will just continue to make the social distancing at 6 feet, again, likely insufficient. The extreme of you can't screen and social distancing at 6 feet or so isn't going to work, would be closing down your businesses, which is also, not an option for healthcare and is not an option for a lot of businesses. So that then gets to an individual's understanding of their own vulnerability, their ability to make good choices, their ability to work with their employer for the right accommodations, so that your employees that are at the highest risk of being hospitalized or, unfortunately the highest risk of death, can make a good choice about coming back to work, how to come back to work, that they can work with their employers and stay as safe as possible while at work. And clearly when you're dealing with nurses and physicians and environmental services, you're going to have people that are risking exposure and need to understand, what's going to happen to me if I get COVID-19, what choices do I want to make, how do I want to interact? And one of the biggest points that we're trying to make is it's not also just about what happens when you are an employee, it's what happens in the rest of your life. So if your employer can help you understand your risk, hopefully you're going to make better choices about going to a party, going out to a bar, other social activities, how are you visiting with your grandchildren, how are you visiting with your grandparents, and really get a better understanding of how to make good choices based upon your vulnerability and what's likely to happen to you. And we think employers, especially because they have access to the employer-sponsored health plan data, can play a very big role in educating their employees and helping them stay safe both at home and at work.
And who better has a charter to raise awareness and instill that kind of behavioral change than healthcare systems, quite frankly. I feel as if that's a pretty core tenet to driving improved community health outcomes. Dr. Showalter, I'd like to make sure we have a chance to poll our audience here around their organization's return to work strategy or return to revenue strategy, revenue recovery, however they want to describe it. So I'm going to put this poll up in front of everyone. I would like to, I'm going to be a little bit nimble here because we've got a great question from the audience around any specific examples where your tools have turned around the thinking of a specific community. I love this question because I love going on the Javion Interactive Map. If I didn't have to keep answering who I am, I would go on it every single hour. That would probably feed my anxiety even more. But joking aside, any examples of where you feel that you've helped shape the behaviors or maybe the approach to protecting one's own vulnerability?
Yeah. So our probably best example of that we had nothing to do with, which is both cool and a bummer. But there were a group of medical students at the Medical University of South Carolina that took the vulnerability map, took the block groups that had the highest risk. They worked with their internal, because they got they got told to stop coming to school, right? So they decided to do something good with their time because they're a mission-driven group. So they worked with their IT group and said, who are people, particularly those over the age of 65, that live in these block groups, and they got their names, they got their phone numbers, and then an army of medical students started making calls out to all of them and doing education about COVID-19, education about how to stay safe, answered their questions, started doing some troubleshooting work with them over accessing their medications, educated them about, telehealth, helped them out with some of the telehealth stuff. So they had a big mind shift there of how to be proactive with a vulnerable community and begin to solve those problems. We've also had other groups that have, used mobile services and van services to help target their highest risk communities and individuals and provide additional services as well. But the medical student example is in our opinion, definitely the coolest because it was them spontaneously responding to the insights that we provided.
Yeah, that's phenomenal. That's a nice alley-oop to where we're going to head next, which is around some of the notions of age-related vulnerability and susceptibility. But first, let's take a look at our poll results. I'm seeing these in real time as well. John, what's your initial impression here?
I think this is a lot of what we're seeing. That coming in, about a third of people are using data. Using some sort of AI to guide them. The CDC system symptom questionnaires are by far the most common thing that we see. We're totally supportive of using them. Anything you can do to reduce the spread or the threat of somebody that's symptomatic that may not realize they're symptomatic, we think is great. Again, the thermal scanning for those that catch it's good. For anyone that didn't realize that they had a fever, and it's surprising how good people can feel, and they have they've got a fever over 101. So, but they're not really feeling that poorly, especially your younger, more asymptomatic group. Yeah, this is right in line what we were seeing. I would love to see more people using data. Would clearly advocate for more use of clinical AI in this space. There are clear use cases where you're going to get benefit and help your employees and your patients.
Yep, that's great feedback. So we're going to jump a little bit to the lack of age-related judgment, like what we saw at Parkland in North Texas, where the age dispersion on ventilators was pretty broad. How do you respond to that?
We saw this really early in our data for vulnerability. It actually took a while to pan out. We had a number of our clients, when we brought forward the list, say that, well, that's not the person that's on our list. That's not, based upon the Wuhan data, based upon what we've pulled from Italy, this, we don't know that this is the right list, and really had to dig into specific examples. Actually, one of our payer clients had a really robust outreach approach, and we ran our vulnerability list, and 50 of our top 100 weren't people that they were planning on reaching out to, and there's a real misunderstanding of the cardiovascular effects. There's increasing evidence of strokes in the 20 and 30-year-olds, increased clotting. Our analysis very quickly showed people with clotting disorders on blood thinners, cardiovascular, heart-related issues, and those under 65 were deriving a lot of risk. Those that have some sort of immune suppression or immune therapy also have had increased risk, and that all runs regardless of age. And we are still seeing, and it's been reported by Dr. Jha up in Harvard, that regardless of age, the mortality rate of those that are hospitalized is at least 5%. So that so those that are at risk of getting hospitalized, or then again at a pretty high risk of mortality. So this is right in line with what we've seen, but is a sizable misconception in the initial reporting that it's just the elderly that are affected. Clearly, they have higher mortality rates, but the mortality rates in the younger group are still way too high to be ignored, and the hospitalization rates are definitely too high to say that this doesn't affect you just because you're 30 years old.
So I'll go a little off script yet again with you, Dr. Showalter. How in the world can static questionnaires respond adequately and in a timely fashion to what seems to be a moving target, an evolutionary issue? I heard you mention a few times just now that we're learning and we now understand that, or we've come to believe that. How in the world can you hit this moving target as it changes seemingly weekly?
I think it's very hard with static questionnaires. It's very hard with classical linear approaches. If then we're going to do this type approaches, it does require a different approach. A different mathematical approach. We saw in the community data that the number of people in a household really matters, which clearly pans out with what we're seeing about dosing. The more virus you were exposed to, the higher likely you are to have a severe infection. That those that are living in close proximity, in tiny homes with lots of people, if one person becomes infected, it's much more likely that the whole group's going to be infected. If it is true that it is airborne, densely packed living arrangements are more likely to carry that, around, to have it linger in halls, to have it linger in elevators, and increase the spread in those communities. And we're seeing that. The data that just came out that are showing that the current incident rates in the African American and Latino population are much higher than that in the white population. Our data indicates that a lot of that is due to the living circumstances and the social terms of care that we saw the whole way back in March doing this analysis. So if back in March, when we had way less knowledge, we were able to get to really good, at least directionally correct answers with clinical AI. It definitely is it has the potential and has been demonstrated to bring that dynamic value as the situation changes, as the approach to reopening changes. How do we respond and react? We need more dynamic technology. On the flip side, we've had some really tragic missteps from people that I think took things too far. We've had the projections back in the winter and spring that we were going to have 50 million infections worldwide within like 2 weeks or something. And people took the technology and took the math and drove it in a direction that it probably never should have gone. And that's back to separating the noise. What's the person's mission? Why are they doing it? And what are they bringing to you? And sorting through that noise is really important, because at the time we were doing this, there were a lot of things done with AI that were very wrong.
So you're really highlighting the importance of a pragmatic interpretation of the data and information that's available. Also evangelizing the utilization of tools and technologies that can at least reasonably match the evolution of our understanding of this coronavirus. And with health systems being major employers of a diverse workforce, you're talking right there, as bringing in essential workers, which are now being looked at as an at-risk population even more so. I hear it almost daily here in the Nashville, Tennessee area. Let's circle back to our audience again. I'd like to follow up with our second poll, back to your health systems or organizations' strategy to bring those employees back to work, bring your peers back to work, as well as address the revenue recovery effort. Dr. Showalter, anything you want to comment on while folks read through that?
Yes, I mean, I think when we're looking at back to work, especially for healthcare, healthcare hasn't stopped working, right? But we do have, thousands of healthcare workers that have been affected with COVID-19. I read the other day that it's up to hundreds of healthcare workers that have died from COVID-19. The NYPD had over 5,000, and this was about a month ago, had over 5,000 officers infected with COVID-19 with over 40 deaths. This has really been impacting and hitting the essential workers very hard. And I think we need to do everything we can to have them, trust that we're doing everything as an industry to help them and to protect them. And one of the things that we do see lacking is their understanding of their individual risk, which has been informed by data that doesn't really hold up. And yes, those groups are at risk, but they're not the only groups that are at risk. And we're seeing the holes in that understanding, lead to some pretty tragic outcomes.
Yeah. Well, I appreciate that, Dr. Showalter. I know we're running a little tight on time. There's just a lot to consider here. Let's talk through really quickly just the high-level components of what this means to your peers trying to create and act upon a workforce or patient engagement strategy. So let's put your health system leader face mask back on. If you could comment quickly on that. And we've got about 4 slides on this, so we'll go through that quickly so our folks can ask a few questions.
Yeah, so I mean, with my health system hat back on, if I was thinking about what I would be, advising our vice chancellor to do when I was, the chief health information officer, I would be letting you know that, there are dynamic education tools out there. There are apps that we can get for our employees and get for our patients where they can interact and they can, from sort of chatbot features, get better education. There are SMS-based technologies that allow us to track those that have been exposed and get daily symptom reports from them over an app or via their phone. I wouldn't be leaning them towards it, but there definitely are facial recognition, thermal scanning technologies that allow people to very rapidly, complete a daily attestation. There's, again, the chatbot type natural language processing that let people do their daily report. That's, what most people know are out there. But there are, additional technologies around understanding the individual's, vulnerability, what they need to talk to their doctor about, that are, there's some interesting social distancing technology out there that can be dynamic about, who you've been in contact with, as well as, flagging if you are, not social, if you're getting too close to another person, and help, let people know if there's too many people in the common area, as well. So there's the technology to help you to track and screen. There's the technology to help you social distance. And then there's technology around, really understanding individuals' risk and vulnerability.
So from a non-technology standpoint, let's talk a little bit about the return to work best practices and tools that are available for leaders.
Yeah, so the really common talked about best practices are the screening and tracking. Some of those are even mandated by the states. clearly figuring out how your patients or your employees can socially distance while doing their job or being part of their healthcare are important. We also include the individual understanding, education, and risk role matching piece as a best practice. We really do believe that we can reduce the negative impacts to employees if vulnerability is matched with the right roles, if vulnerability is matched with the right equipment. So we had an example of talking to a employer that was doing deliveries that had to be taken the whole way inside to a hospital, and they weren't sure what they were going to do with those employees. And we came up very quickly with, well, you're vulnerable employees, let's do enhanced, why don't you guys do enhanced cleaning protocols on those trucks, and although they're not in big supply, this does sound like a group that if they're vulnerable, an N95 mask for that delivery while they're actually in the health system makes some sense. So it's a not widely accepted best practice, although I would definitely advocate as a best practice to match the vulnerability of the individual with the risk of their role and make any adjustments if able.
Yep, that's great. So that we can address a couple of the questions here, Dr. Showalter, would you like to quickly summarize the key takeaways that you'd like to make sure your peers within the leadership and the physician community take away from this?
Sure. So first, I do big takeaway for me is that there are technologies out there that provide insight into vulnerability, to understanding what the risk of an individual person is that considers their health and their social circumstance. The second part is that there is a lot of noise out there, but there's also signal in that noise. There are good technologies and good partners out there to help you with the back to work strategies that are truly mission driven on this, and that there are groups like Pivot Point, like KLAS, that can help you sort through who those partners are, and have been trying really hard for the last couple of months to bring that to the surface.
Yeah. Thanks so much. Dr. Showalter, let's jump into a few questions here. I have them up on our wonderful little chat widget. First one, I like this. Is AI the canary in the coal mine? These are friends from Appalachia asking this, or out west. How can we use this actionable data to get communities to prevent surges and outbreaks throughout their communities?
Sure. So first of all, I love the canary in the coal mine question, because I grew up in central Pennsylvania, so I totally get it. And yes, I do think that there's a role for this, especially when combined with reported instances and an understanding of the spread in communities. If you're beginning to see spread inside a vulnerable community, that combination is very concerning. The vulnerable communities do have a higher spread. They do have higher hospitalizations. They do have higher mortality rates. So as you begin to spread into that area, it becomes very concerning if you're the health system, understanding what's going to happen to your resources, understanding what's going to happen, from a surge perspective. I do think it is the canary in the coal mine. It has to be granular, though. The county level, the census tract level is not really going to help you out on that. Understanding what's going on at a very granular level, at a block group type level, and understanding that things are going bad in this block group are things that can lead to alterations in your plans that you can have responses to, and that you can begin to either set up mobile testing, to set up mobile clinics, and get to those communities and get those communities the help that they need, both for that community and for the communities surrounding.
Great. So before we get to our last question, I do want to make sure that we provide our final poll question to the audience. And I will ask you, Dr. Showalter, kind of part and parcel to the last question. The state of California took the initial data and prevented surges and COVID-19 transmission. The state's lack of discipline has caused surges similar to other states that opened up and ignored the science. What happened since the data, sorry, I'm trying to read this tiny font. What happened since the data did not change?
So, wow, there's a question in there that, definitely gets to people's tolerance for lockdowns, people's understanding of risk and fear with regard to that risk. What I will say is that there's been some very unfortunate things. So we knew from our data that that San Quentin was a very high risk area. I mean, we colored it purple, but it was a bright purple. And they're in the middle of an outbreak because prisoners were transferred in that were symptomatic, which was, clearly a retrospect high risk thing to do. But the diligence that is occurring at the community level, the diligence that's occurring at the state and municipality levels, for whatever reason is driving them, are unfortunately not enough to contain. And the data hasn't changed, and it's from someone that's on the side of watching the data, it's been very hard to watch, because it feels like a lot of this should have been preventable. We understood where the communities were vulnerable. We've watched vulnerable communities have really bad outcomes. And unlike with H1N1, there was a way to know it, and people knew it. And not everybody completely tackled it, but, maybe, hopefully, fingers crossed, should there be a next pandemic, we'll understand vulnerability and do a better job with those communities. But we definitely, in my personal opinion, we have failed a number of those high-risk communities from a lack of ability to be really disciplined. On the flip side, I do think that employers have the ability to step up, especially health systems, to step up and begin to consider that vulnerability, not only in their employees, but also in their patients, and really have discipline around helping those that are most vulnerable, that they are, individually responsible for it.
Certainly. I appreciate those words. Out of sensitivity to our audience's time, I want to make sure that we wrap this up pretty soon. Any immediate responses, Dr. Showalter, to the survey results here? Either we had 3 participants on that, or that is a very interesting distribution of answers.
Well, I'm excited to see that time isn't one of the barriers. The other 3 make sense. Operational integration it can seem very daunting to figure out how to operationalize, integrate these kind of insights. We've experienced some really good examples of, getting them into the decision making about who gets mail to pharmacy, getting outreach calls done, getting mobile units sent to the right communities. And the confidence that clinical AI will have immediate impact. There's still a lot of, skepticism around what clinical AI can do. But, we've definitely seen the accuracy and the ability to predict and warn and be that canary in the coal mine. We've also seen the impact that, targeted outreach can have on chronic care management, as well as COVID-19. We've done matched controlled studies that show several $100 cost savings when you add clinical AI to transitions of care to chronic care management, and we're right now in the middle of some randomized controlled trials, but the health system's skepticism on it, I think is a healthy skepticism. But I do think the risk reward right now for patients and employees clearly leans towards the reward side when we're talking about, addressing COVID.
Well, that's fantastic. Dr. Showalter, we do have another fantastic question I really like, but for those that need to drop, I just want to say on behalf of both Pivot Point Consulting and JBeyond, and with roots back to the class research efforts, I want to thank our audience for joining us today. And those of you that can stick around for just another minute or two, Dr. Showalter, I really like this question from the audience. I've got lots of immediate priorities related to return to revenue/work. How does clinical AI really fit in? It's not front burner for me right now. Why should it be?
So, I think it should be front burner right now because it's what's going to evolve as the situation evolves. So, highly responsive AI that can actually help you answer the problems that you have today really does change. So, for the COVID-19 example, we quickly went from communities to individuals to helping on the post-infection hospitalized side, understanding who was going to need vents, who was going to have a mortality event, and then moving to employers. So as the circumstances evolved, as the need evolved, the AI also can evolve to meet the need. So the ability for AI to adapt and not be static as opposed to a survey, I think is a top reason for it to be front burner. The other reason for it to be front burner is it does not look like COVID is going away anytime soon, but does continue to evolve, and the situation continues to evolve. So once flu season hits, and we've got COVID-19 and flu season, and then probably the impacts of deferred care coming with regard to return to financial stability, being able to answer those questions and adapt and understand how vulnerability and risk plays into your decision making around those topics. I don't think people are going to make the most informed and best data-driven decisions if they're using something static. So getting the right technology in place to support your decision-making, both at an individual level and a system level, would be a high priority for me if I were still in the CHIO role.
Fantastic. Dr. Showalter, thank you so much. To our audience, we're so grateful that you joined us, and we hope that you've benefited from today's conversation. We'll be sure to send out contact information aside from what you can see on the slide, as well as the archive for this recording. That'll probably come out later today, so you can revisit these discussions and socialize with your peers that weren't able to join today. Dr. Showalter, thanks again. Thanks, everyone. Have a great day.
Thank you.